Good afternoon, everyone. Good afternoon. Good afternoon, Dr. Lang. For those that don't know, so you can say it much louder in the next second or two, my name is Dr. Tony Lang, and I'm the director of the Morton and Gloria Shulman Movement Disorders Clinic. And so I'll say good afternoon, everyone. Good afternoon, Doctor. Very good. They learn well quickly. Okay. Welcome to what I think is now the fourth or fifth of these sixth, holy mackerel, the sixth of the speaker series that were the brainchild of Liza Jerome from the foundation, and when she first came to us discussing this idea, it really rang a resonance with the faculty. We recognize the importance of sharing what goes on in our field with the people who are touched by the diseases that we deal with. And I think it's very important for you, and I hope you appreciate that you are family. In fact, yesterday I saw a patient. We had a very nice, good resident working with us yesterday, and two of our patients complimented this young guy for the great job he was doing. But one of the patients said, you know, I came and I sat in the waiting room and everybody welcomed me and it was friendly and we chatted and I felt like I was a part of a family. And I hope that a lot of you feel that way. I know you don't want to come to a movement disorders clinic. I know you don't want to have the diseases that we're seeing you for, but I hope you feel welcome. I hope you feel well treated. I hope you feel respected. I hope you feel that you're part of the team trying to solve the problems that we're all working to solve to get rid of these diseases. So we have a common goal, all of the faculty in our Movement Disorder Center, to solve the diseases and hopefully eradicate them eventually. Now that's wishful thinking, admittedly, but I've always said that when I'm ready to retire, and I'm getting a lot grayer, but I'm not ready for retirement yet, but when I'm ready for retirement, I really want to be able to look back and say, I've seen the course of these diseases change in the time that I've been doing it. And I think that the work that we're doing here at the Morton and Gloria Shulman Clinic and the Edmund J. Safra program in Parkinson's disease really is getting to where we need to be. And you're hearing at these speaker series lectures cutting edge work by people that really are very dedicated to getting those answers and trying to help you really change the course of your disease. So we're very fortunate today in having Dr. Robert Chen speaking to us. Now, I just remembered one thing that I wanted to say before we started. Those of you that have attended these talks before may remember, I hope, that we've always thanked John and Sheila Milne for their ongoing support. They've been very supportive of these particular speaker series in the past. And unfortunately, since our last meeting, both of them have passed away. And so we have passed our condolences to the family. They were strong supporters of what we're here to learn from and celebrate, and hopefully their contributions will see us move forward, and hopefully today you'll see some progress in that area. So Dr. Chen, we were very fortunate to recruit away from a couple of other big Canadian centers when he was starting to look for a job. He trained in electrophysiology. He actually worked here as a student, right, with Dr. Peter Ashby. So I knew him when I was first starting my faculty position here, and he worked with one of our electrophysiology colleagues and described some really important aspects of some of the disorders that we deal with. He then went away and did neurology, trained at the NIH with a very famous electrophysiologist by the name of Mark Hallett, and then started looking for a job, and we were very fortunate when he accepted a position here. I've fought to keep him here, and fortunately I've succeeded so far. Be nice to him so he stays. Because as you'll see, he's doing work that I think is really quite unique. He and many of the people that come to speak to you at these speaker series are international, renowned experts in their own right in different fields. So at every one of these sessions, if you've been attending, we've talked about drugs and pharmacology, we've talked about surgery, we've talked about basic science and cell mechanisms, and now today you're going to hear about electrophysiology. You're going to hear about how Dr. Chen studies brain function both in normal individuals and in individuals with the diseases of interest. You're going to hear how he's really expanded our understanding of how interventions change the brain. For example, deep brain stimulation. I'm sure he's going to tell us a bit about that. So I'm going to pass you on to Dr. Chen. He's going to spend a fair amount of time presenting to you. Then I'm going to come back. I've got other commitments, so I'm going to run in and out, but hopefully I'll spend a fair amount of time here. And then I'll come back and sort of direct the question and answer and wrap up. And then at the end, if you're interested in hearing more about research, or if you're interested in participating in any of the research, we're going to have people with trainee stickers on their chests so that you can talk to them and find out more that's happening in Dr. Chen's laboratory, for example. Now, Dr. Chen, foolishly, has, well, initially not foolishly, he played tennis and injured himself, injured his calf, and then foolishly was traveling with an injured leg and tore the Achilles tendon further, or tore his muscle, and has had to have surgery. So we're going to allow him to sit down and look nice and comfortable and present to you. And take it away, Robert. Right. Thanks very much.
Okay, thank you. Okay, well, thank you very much for coming. It's a pleasure to come and speak to you today. Let me see. Okay, you can see the slides. So, what I'm going to talk about is something called brain plasticity, and I'm going to talk about how this is related to Parkinson's disease, dystonia, and how we have studied this entity we call brain plasticity. Okay. So, what is brain plasticity? So, brain plasticity is basically the ability of the brain to change and adapt. And it's a very important function because, well, it relates to how the brain cells change, but perhaps more importantly, how one brain cell, one group of brain cells are connected to the other group of brain cells. So how different brain regions are connected to each other. So it is a process, it's very basic, it's underlying like learning and memory. So we have to have brain plasticity, able to learn and remember things. It is something that mediates, so we have a brain injury, say a head injury, a trauma, or a stroke, someone recover from it, it is mediated by this process of brain plasticity. So that is a very important process to study. However, plasticity is not always good in that sense. So some of you may know, for example, that people who have amputation may have something called phantom pain. So basically they feel that there's pain in the arm or leg that's amputated already. And this is thought to be due to an abnormal type of brain plasticity. So, but the reason I'm talking about it today is that we and others have done studies to show that brain plasticity is abnormal in people with Parkinson's disease and dystonia. Okay. So how can we study brain plasticity? So there are people who study animals, so we can say put a recording instrument, electrode an animal, and record brain activity, but also we don't do that in human subjects. So different ways that we can use to study brain plasticity. So, but in this talk, I'm going to concentrate on two methods. So the first method is we call transcranial magnetic stimulation, or we can also call magnetic brain stimulation. And the second method, touch on briefly, is called functional and magnetic resonance, or MRI. I think many of you are familiar with MRI, but functional MRI is a slightly different type of MRI. So I'm going to first talk about transcranial magnetic stimulation or magnetic brain stimulation. So what is it? So it is, we call so we want to stimulate the brain and see what happens when we stimulate the brain. But we want to do it because on non-invasive manner. Non-invasive means that there's no surgery involved. We can just put something on the top of the head and stimulate the brain. So the way it is done, I think some people who are interested in physics of this, is that we put a wire coil on the head. The wire coil has a current, electric current go through it, and people who know physics is that this will induce a magnetic field that's perpendicular to the coil, and this will in turn induce electric current in the brain underneath. And for the interest, the current that flows in the coil is opposite direction to the current that flows in the brain. So in a sense, we are stimulating the brain indirectly through a magnetic current induced through the scalp and the scalp. The way that we usually do it, we put a coil on the top of the head. They come in different shapes. So we show you this called a figure 8-shaped coil. It's more focal. We just stimulate a small area. And what it will cause a twitch. They say, because the left brain controls the right hand, and the right brain controls the left hand. So you stimulate the left brain, you cause a twitch in the right hand. And we usually do is use recording to record the twitch activity, and we can measure it and quantify it. So this is just an example. It's someone sitting here, putting a coil on the head and recording activity on the other side, hand muscle to stimulate the brain. So what we're going to do here now is to have a demonstration of this magnetic stimulation. So you just see what it's like. So we have several colleagues from my lab here. Now what we're going to first do is, so this is a, so we induce a fairly strong current and a magnetic field. So what Neil is a postdoctoral fellow in my lab, so he's going to first demonstrate what happens if we stimulate, this is just an aluminum can, because it's metal, right? So metal and magnetic, and so Neil is going to demonstrate what happens if we stimulate the aluminum can. Okay. Okay, and then you can see there is a movement. You can try again.
There's about an inch gap between the coil and the can itself. Even more.
Okay. Okay, so for this, we actually, I mean, some of you may have MRI before, so certain people should not have this. People who have like a metal clip in the head should not have this. The similar people should not have an MRI, okay? Now, Dr. Garno is a fellow. So Neil is going to, so what Neil doing is that she's stimulating her left side of the brain. So this will cause a twitch in the right side, in the right hand. Okay, so can you see that? So we can focus. Yeah, so I think you can all see on the screen there's a twitch that, okay, maybe just one more time. Yeah, okay, good. So this is just a simple demonstration. So we can use this coil, put it on the head and cause a twitch on it. So in the study, going to show you is that we basically measure this, we can quantify the degree of activation of this twitch. Okay, okay, I think that's, maybe we can say, ask Corinne, how did it feel? Yeah.
So it just feels like a little tiny touch over the scalp, a little pinch, and then it just feels a little bit weird because your arm is moving without you wanting it to move necessarily, but it's not uncomfortable. It's just surprising sensation. That's it.
Great, thank you very much. All right. Okay. So what I'm going to do next is just tell you some studies that we've done using this method to study brain plasticity. So the way that one method we can do it is the method that's called pair-associative stimulation. What is done, basically, we stimulate a nerve, so the nerve in the wrist. The nerve will send an impulse up to the brain. And it takes about 21 milliseconds. So 1 millisecond is 1,000th of a second. So it's a fairly short time, but it takes some time for the nerve impulse to reach up to the brain. And we try to do is that we time the nerve impulse and this magnetic impulse at the same time. So you have to time it precisely. So what the brain cells happen to the brain cell is that it has an impulse coming from the nerve and then the impulse coming from this magnetic stimulation. So when the brain cells get two impulses come in at the same time, it's a learning, it's like a learning process. And we do that repeatedly. Basically, we do this once every 10 seconds for half an hour. We will induce a type of brain plasticity. And what we do here is that we do some measurements before we do this, and then we do some measurement immediately 30 and 60 minutes after we do this intervention to see how we can affect the brain. And this particular study, we studied people with Parkinson's disease. So people with Parkinson's came on two occasions. One occasion, they don't take the medication, we call off. And the other occasion, people are on the medication, so we call that on. Okay. So this is the result. This is a control is a normal person without Parkinson's disease. So this is the twitch that we can record from the hand before the intervention, so you can just recognize the size of the how excitable the brain is. You can see that this is before, and this is 30 minutes after we do the plasticity intervention. You can see that the response becomes bigger in this normal person. So this is what we expect. So this intervention will make the brain more excitable. So we put the same impulse in, we got a bigger response. But this is in people with Parkinson's disease. So this response in this person is a baseline, but after the intervention, there's no difference. So in this particular person with Parkinson's disease, we do this intervention, there's no change. Whereas in normal subject, the response becomes bigger. And it doesn't matter if the person is on or off the medication. So we often do this in a whole group of people, and we did find that there is people with Parkinson's do not respond normally to this intervention that induces brain plasticity. So we see a normal subject, but not in people with Parkinson, and whether the subject is on or off medication. So the next, I think some of you will know that one treatment for Parkinson's disease and dystonia is called deep brain stimulation. So not going to talk too much about it. So I think you know that it's electric put in the brain, is connected to a basic pulse generator, battery pack that gives stimulation to the deep brain structure to help with people with Parkinson's disease or dystonia. Now the thing about this is that we actually don't really know how it works. So it's open question. There's some ideas, we don't know exactly how it works. So what we'd like to know is that does this treatment with deep brain stimulation change brain plasticity? So we do is we have people who have deep brain stimulation. These are people with Parkinson's disease who have, we call subthalamic nucleus deep brain stimulation. So we stimulate people who have deep brain in there, and then we use the magnetic stimulation to stimulate the surface of the brain to test the brain plasticity. So in this study, we have people with Parkinson's disease who have subthalamic nucleus deep brain stimulation. They're very generous that they come 4 times. So 2 times they are not taking medication, but we also switch the stimulator on and off. And then 2 times they're on medication, we switch the stimulator on and off. So what you're seeing here is the response to the plasticity intervention. So 1 is baseline. So no change is 1. This is minutes, so 60 minutes after the plasticity response. So in a normal subject, in the green here, you see that the brain become more excitable, about 1.5 to 2 times more than baseline before we do the plasticity induction. But in people with Parkinson, when they have medication off, there's no response. And the only time there's response is when the DBS, the deep brain is on, and the medication is on. So what I think it tells us is that the medication does not seem to, at least in this group of people with Parkinson, does not restore the plasticity response. But the deep brain stimulation does, together with the medication. So there is this black here is this condition. Those people have the more or less a normal response, brain plasticity response. And the other we have done is we began to look at how does the deep brain stimulation works, how it's related to plasticity, is that we want to induce, so this time we are pairing the deep brain stimulation with the magnetic stimulation that I show you. So, and we choose certain times, so they deliver at very precise times. Based on our previous study, we're 2 times, which is 3 milliseconds, 1 millisecond is just 1,000th of a second. So these are very short times. We pair these repeatedly. And we think that by pairing these repeatedly, we can make the brain more excitable. And we have a control, which is based on our previous study, we think that this will not change the plasticity. So the results here is that the 2 intervals that we, based on previously think would induce plasticity, does induce plasticity. So the way to read these graphs, 1 is baseline. So we have things above 1, that the brain become more excitable. And we do this at 0 to 15, 15 to 30, and 30 to 45 minutes after we induce the plasticity. So what these studies show us is that we can induce brain plasticity by combining the deep brain stimulation and the magnetic stimulation you just see. But we have to time it at a certain specific times to induce this type of plasticity. Okay, so in summary for Parkinson's disease, what we other people have found is that general brain plasticity is decreased in people who are more advanced Parkinson's disease. And deep brain stimulation, together with medication, it can restore this brain plasticity. And we can induce the brain plasticity by combining these together, deep brain stimulation together with the magnetic brain stimulation. Okay, so I just want to switch gear a little bit and now to talk about another condition that we see is dystonia. So some of you may not be familiar with dystonia. So dystonia is a syndrome. We call it a syndrome because actually it has many causes of dystonia, but generally it's characterized by people with intermittent or sustained contractions and often causing like a twisted posture. It can affect any part of the body, eye, neck, arm, leg, or sometimes the whole body. So there are various types of dystonia. This is one common type because cervical dystonia affects the neck, so people can have neck turned to one side, tilt to one side, forward, backward, and often a combination of these movements. Just another type of dystonia is called writer's cramp. So in writer's cramp, people would often have, often they're doing quite fine, except when they try to write. So when they try to write, then they will have abnormal postures. A picture of someone, when they write, he have this extension of the index finger and the thumb. And often in this condition, it's called task-specific in the sense that often people affected, nothing else wrong, only problem is when they write. Okay, so and there are many other forms of dystonia, just two examples of dystonia. And again, so we're going to show you some study we did in dystonia with people who has deep brain stimulation. So, the method we use is we call EEG. So this is brain wave recording, and again, the magnetic brain stimulation. So what we want to know is understand what happened when we do deep brain stimulation, and what happened to the rest of the brain and how it works. So this is electrical brain wave recording, or EEG. So these are people with dystonia, they have a deep brain stimulation implanted, and we want to know when deep brain stimulation is working, how does it affect the brain waves? And we did find that there are we can record brain waves using a cap, and there's specific times the brain got activated. So at 10 milliseconds, there is a negative wave, and then at 25 milliseconds after each pulse is a positive wave. So we clearly find that the deep brain activate the surface of the brain with brain wave recording. And again, we also want to induce plasticity in this setting. So again, we pair this deep brain stimulation together with the magnetism you just saw, and we paired repeatedly and do some measurement before and afterwards. And similar to what we found in Parkinson's disease, we also found that when we pair this deep brain stimulation together with magnetic stimulation, we're able to induce a brain plasticity. So this is one pairing at baseline, and then after the intervention, we get a bigger response. So again, one is baseline. So we have two times that, based on our study, we think it's a suitable timing, and we did confirm that induce plasticity in the brain. Whereas at different times that we think that is not the right timing, it has no effect. So now the other study that we are currently doing is looking at, again, using this magnetic brain stimulation. Now, I should actually, I should mention magnetic brain stimulation is actually not only we can use to investigate brain function, it can be used as a treatment. So currently, this magnetic brain stimulation is an approved treatment for depression. So there are people, actually some of psychiatrists in this hospital runs clinic that use repetitive type of magnetism to treat depression. But currently it's not approved for treating any other conditions. And we have done some studies in the past, for example, using to treat Parkinson's disease, and did show some promise. But what, in this particular study, what I want to show you is that we use this magnetic stimulation, we stimulate the back part of the brain, called the cerebellum. The cerebellum is part of the brain that is important for coordination of movement. And many recent studies show that it is abnormal in both dystonia and Parkinson's disease. But in this particular study, we just published about a month or two ago, is that we stimulate the back part of the brain, called the cerebellum. And what we looked at is, do we change the connection from the cerebellum to the rest of the brain? So what we do this, we use, we call functional MRI, so magnetic resonance imaging. So this way we can do is, we can look at connections from the cerebellum look at X here, and this is the rest of the brain regions. This is the rest of the brain region that's known to be connected to the cerebellum. So what we did, and we have a particular type of stimulation, is called CTB, stands for continuous theta burst stimulation. But that, I think, doesn't matter. Basically, it's an intervention, and we show that we can reduce the connection from the cerebellum to the rest of the brain after the subject has received this intervention. And there are studies to show that, for example, there may be abnormal connections between this cerebellum and the rest of the brain area. So what we are currently, next step we're going to do is probably to study people with dystonia and see if this, first of all, is a connection abnormal, and if this type of intervention can correct the abnormal brain connections. Okay, so to summarize for dystonia, what we show here is that the deep part of the brain, which is the basal ganglia where we insert the deep brain stimulating electrode, is connected to the surface of the brain, and it happens at very exquisite times. And we can induce brain plasticity by pairing the deep brain stimulation with the surface brains at very specific times. And we can stimulate in one part of the brain with the deep brain stimulation. Sometimes can increase, sometimes can decrease the connections. So what are the implications of this kind of study? So first of all, I think these studies clarify we do deep brain stimulation, but we don't understand how do the deep part of the brain connects to the surface of the brain. So I think the studies first clarify what's the nature and what's the timing of these connections. And we shed light on how deep brain stimulation works. We show that deep brain stimulation can work by changing brain plasticity. And perhaps I think it also implication for potential treatment in the future. If we can pair these, for example, deep brain stimulation with a surface brain stimulation at specific interval, so this can be explored in the future as a potential treatment based on also with further research that we have to do. So I just want to comment a bit what our current studies we're doing in the lab and what the future studies. So we have a number of current projects. So we are currently investigating how brain connections, we're interested in how one area of brain connects to another, for example, the cerebellum, how it connects to the rest of the brain. So how it's affected in people with Parkinson's disease, and particularly people with freezing of gait. How is it different from people with freezing of gait, have a different connection from people who do not have a freezing of gait with Parkinson's disease. And we are further exploring, I think it just showed you that cerebral stimulation as a potential treatment for people with freezing of gait. And in the dystonia, we are doing some studies. Some of you may know that we use botulinum toxin injection as a treatment for certain forms of dystonia. So we are investigating how does this treatment, botulinum toxin injection, changes brain plasticity. We think that the way it works, at least in part, is by changing brain plasticity. And then we will going to be looking at the effects of the cerebellar stimulation. I just show you on how does it affect brain connection. We want to see if it can normalize. We know it's abnormal brain connections in people with dystonia. And the other, so probably longer term goal of our work in the lab is that we want to establish a more effective way to induce brain plasticity by pairing the deep brain stimulation with the magnetic stimulation that I show you. And other projects that we do in the lab is to record from the deep brain signal people who have deep brain stimulation and help to design, if you like, the next generation of deep brain stimulating devices. We think the next generation of deep brain stimulating devices will be smarter. We know what the brain is doing and can automatically adjust the stimulation to adjust to what the person is doing, what the status of the person is. Currently, we're not at that stage yet. And I just want to, because I think our research has been very grateful for people who have generously donated their time to participate in research. Without people coming to us, we cannot really cannot do anything. So I just want to emphasize that participation research will help to move the field forward, because without research, we cannot move the field forward. I just want to also acknowledge the number of funding agencies that supported our work. Main funding is from this CI Joint Canadian Health Research, but I want to very acknowledge the Toronto German Western Foundation, which organized this event today, has supported the work that we did. And the other thing I just want to acknowledge, so I think this slides, and some of you know, this is the neurologist at our Movement Disorder Center. I think some of them have talked before in these sessions before, some of you may know at least some of them. And then this is some people work in my lab. This is a bit older slide, some of the newer members are not there, but again, I just want to acknowledge them, and that because many of the work that I show you is really the work they do. So thank you very much. Again, so what I think maybe we'll do is ask Andrew to come up. Andrew? Oh, okay, good. So Andrew is someone I know for a long time. Andrew has dystonia. So I think Andrew is going to talk to us about his experience, and the other thing was that Andrew has also participated in our research study as well. So,
thank you.
So maybe after Andrew, then we can wrap up, and we will take questions from all of you. Okay.
So I've had dystonia since probably I would say 1977. And at first I didn't know what it was. I didn't know what I had. I didn't know what to do about it. I was working in industry, and for about 5 years after I first graduated from university at the undergraduate level, and I noticed I was there for 5 years, and roughly the third year I noticed a problem I had with my writing. But towards the end of that 5-year period, I couldn't even hold a pen properly. So you saw a picture of a gentleman holding the pen and with the thumb kind of raised. Well, at this point, I couldn't write unless I held a pen like this. And, you know, the writing was absolutely terrible, but that's the only thing I could do. I couldn't do anything about it. Now, an interesting thing occurred. I didn't like the business world, and I tried to get back to school and do a doctoral program, and I finally got in one of the programs at the University of Toronto. But then all of a sudden I freaked out. I was in a humanities and social science study, so all of a sudden it occurred to me, I'm going to have to write tests, exams, you know, it's not multiple choice where you can tick off, but I'm going to have to write long essays with my pen. And I was in the Toronto, I remember this evening very vividly, I was in the Toronto Public Library one night, and they had we didn't have computers then, so I was just leafing through the cards in the catalog. And I was going to write some notes, try to write some notes in this really awkward fashion on the books I was interested in. And all of a sudden it occurred to me to try my left hand. So I picked up the pen, and lo and behold, I could write very legibly with my left hand. So for 5 years in the doctoral program at the University of Toronto, I wrote all my exams, all my tests with my left hand. No problem. For some reason, when I graduated from the PhD program, all of a sudden I couldn't write with my left hand anymore. But I couldn't write all that well with my right hand either. So at some point, I did a bunch of work as a postdoctoral fellow. I had a stint at McGill University for about 4 years. And then I went to the Middle East. And then my dystonia got really bad in both hands. Like when I was there, my hands started twitching quite the muscles are overactive in the arm. So, you know, especially the index finger, this finger, the thumb, and these two fingers, the index and the thumb, you know, they would just twitch uncontrollably at certain periods. Sometimes it would subside, but, you know, there was no treatment for this there, for sure. I didn't know about the treatments here, but my friends took me to an acupuncture clinic one night, and they seemed to hook up needles in my body everywhere except my hands, which I found kind of strange, especially, and there was one at the top of the head. So yeah, okay, fine. I did that for about half an hour that evening, or lay on their bed and with these needles. It must have been a half an hour. It could have been a bit longer, but it felt better. My hands actually felt better for about a week. But then all the symptoms returned. So the twitching, the kind of, not writing aspect, all those returned. So I got back to Canada after a couple of years in the Middle East. And, my hands would, at time, it was really noticeable. Like my mother noticed that, there's this unusual movement in my hands. And she said, look, you got to go see a doctor about this. And I was reluctant because I didn't think there was anything for this. So anyway, one thing led to another, and I ended up with in Dr. Ashby's office, who has been mentioned earlier. And I got there, and I learned very quickly that he was known as the EMG king. That's what they referred to him as. And he was, the top guy in this area. So they had this technique where they would inject, with sort of needle probes, they would, find the muscle that's of interest, that's responsible for the twitching, and then inject a little bit of Botox right in the spot of the muscle, the spot in the muscle that's activating, doing this abnormal activation of the fingers. So that was pretty cool. And this was remarkable. This was like a miracle to me. I mean, I could start, writing. It was still uncomfortable, but not. I didn't have to hold a pen like this anymore. I could hold it properly. Now, if the Botox started to wear off, and for a time I could write pretty much normally with my right hand, but once the Botox started wearing off, if you will, then the movement was not so much what you saw in the picture with the thumb kind of going up that way, but my index finger and my thumb would kind of ride up as I was writing, like that, like literally exactly in this fashion. And that created a problem with the writing because I couldn't write properly. But, for extended periods, I could actually hold a pen properly and write. And this technique used by the doctors here at Toronto Western was a first. I understand your group invented this protocol. Is that correct, or?
I probably wouldn't say we invented it, but we're certainly one of the very few places that do this type of injection. I mean, because I think what Andrew was showing, this injection is very precise targeting of the muscle. So we are probably one of the very few centers, at least in Canada, that do this type of injection.
Yeah, so the needle, like the way they pinpoint the muscle in question is that a needle goes in, it's an electrode basically, it's hooked up to an EMG machine. So Dr. Chen, he'll pinpoint the area, and then he'll either listen to the sound waves that are coming from the computer or look at the waves. I think you do more listening than looking, if I recall. So, and that technique really works well. Now, when I moved out to the east to work at one of the universities at one point, in New Brunswick, and they knew nothing about this technique. But I did get a doctor a neurologist who would inject the Botox. But what he did was very interesting. Like he would kind of feel around and ballpark the muscle in question. Like I would, move my fingers, and then he would ballpark the muscle. Now, Dr. Chen does something similar. He ballparks it, asks me to move my fingers, but then he pinpoints the exact location with this electrode that we just talked about. Now, this ballparking method out east, it did not work. I mean, the difference was amazing. It was just absolutely amazing. It kind of made me feel a little more sort of at ease, with the arms. But if I tried to write or anything like that, it was a night and day the difference. This technique is absolutely marvelous in terms of my experience. Now, the other interesting aspect to the study that was just talked about, now you saw the fellow, sorry, I forget your name. Okay. Now, we saw a zap, and you said it was not that uncomfortable, or it was a big deal. And I agree with that. I participated in the study. I went about 6 or 7 times on a Friday morning, I think, for about 3 hours at a shot, and they just zapped me for 3 hours, with a few breaks here and there. But there was 2 moments, I think, possibly 3, but certainly 2, where the zap was not, half a second, but it was, I forget what it was, but it was either a minute or 2 minutes, but I swear it felt like 15 minutes. And, they put the electrode on my head, and then, they zapped me for like, let's say 1 or 2 minutes. And then the technician at the end of it, the very first time they did this to me, she kind of, after the procedure, she said, well, that wasn't too bad, was it? And I looked at her and I said, think Guantanamo. She started. I'm exaggerating a little bit, but that was my first impulse to say that. It was not. I do not recommend this procedure if you can avoid it. Anyway, it was great to participate in the study. I'm happy to make a contribution. And other than that, all I say is that the doctors here are doing wonders, because for me anyway. Oh, I should mention that. I was just going to say, for me, it's worked, wonders. Now, I said, I think not last time, Dr. Chen, but the time before, I think you asked me, well, how's it going? Is the treatment working and all that? Mm-hmm. I said, it always works. And Dr. Konsky was right beside Dr. Chen, and he goes, well, it doesn't work for everybody. So, it works for some people, I guess. And you would know more about this than I would, but for me it's been great. So I appreciate the opportunity to tell my story, and if there are any questions, I'd be happy to answer.
Right. Well, thank you, Andrew. So I just wanted to say, Andrew, I think when you mentioned I think it's very common for dystonia to actually didn't get a diagnosis until they see it now, because I think Parkinson's is people like general practitioners are much more knowledgeable, but dystonia, I think, at least many cases, many practitioners are not familiar with it, so they think it was something else. So it's not uncommon for us to hear the story that have seen other doctors or tried the treatments, not getting properly diagnosed. So okay, so I think we'll open up to questions. We're happy to answer questions.
Yes, in my own personal experience, I have the same problem. I'm a lefty, so going through school in the past, I always had trouble writing. But a number of years ago, I did develop involuntary movements with my fingers. And now and I did go to see Dr. Adam. He was with Dr. Gutman in the Parkinson, out in Scarborough, that area. And he did give me Botox, and I did find it helped, but it was very painful. right in the muscle, I would go every 2-3 months, and he gave me 2 injections. And one of my questions, I guess, is that covered by OHIP? Because I found it was over $400 the injection. It's a little amount. And he was able at that time to get me to have the government pay for it. So I'm not sure if that's available for everybody, the Botox. It is expensive. And I did find it very helpful for me. I was able to write. I'm retired now. One of the reasons is that I just can't write. And I think I have a form of writer's cramp. I don't have involuntary movement, but I just can't write. My hand freezes. It's like that, and it's just I feel like I'm not getting the waves from my brain to my hand. So basically, I guess my question is would something like that be helpful for me at this point? I don't have involuntary movement, but I've got like writer's cramp. People look at me and they say, "What's your problem?" I say writer's cramp, they don't really know what it is. And I know it's a form of dystonia. I don't know if it beats the Parkinson or not, but if you could just perhaps help me in that regard, I'd be interested in going to doing the procedure and as a research.
Okay, I think the first one question is it covered by OHIP? So I think the question, it depends. So it is not automatically covered by OHIP, because, but some people have private insurance, we cover private insurance, but what we do is basically write to OHIP to, we call this exceptional access program. So to see if they cover, it's no guarantee, but my experience, sometimes they do cover it. We have to write to OHIP. The question is whether your situation is worth looking to injection that. I think we will have to see in more detail to discuss it, because I think it depends on the individual person. Yeah.
So I'm going to help chair the questions as well, and I'll comment as we go. So the first thing is botulinum toxin is a drug, so it's very different from something the doctor does. Our component of it is covered by OHIP, obviously. So the doctor's performance of the injection is all covered. It's whether the drug is covered, and that depends on your program and whether you're insured or not. And as Dr. Chen says, we are sometimes successful in getting it, depending on what the problem is. The government will consider supporting it for some indications and not others. And as he said, it also depends on the nature of the muscles involved as to whether we think it will help you. And as you heard, Dr. Konski very correctly had said that some patients are helped and other people are not, especially with this writer's disturbance. And for those that haven't heard of it, writer's cramp is not what we all experience in school when you're writing a whole bunch and you get cramping and aching in the arm. That's not what we all got when we wrote essays. It's a very different motor abnormality related to the way the brain is talking to the muscles in the act of writing. And so in a way, it's sort of a disturbed, as you heard, disturbed plasticity in the brain that has induced this. You might be interested, you've all heard of Botox, even though you've not received it. Botox, hot in the press because it's used for wrinkles and other plastic surgery purposes. Interestingly, the term Botox was coined by a movement disorder specialist. So in our field, not in some other field, but it was coined by Dr. Stanley Fon in New York, and they were one of the first centers that was using botulinum toxin injections. It's actually botulinum toxin A type. There are several different types of botulinum toxin. This is the A, and there are actually several manufacturers of the A type now. So actually Botox is the one manufacturers, they actually grabbed that name and they copyrighted the name after Dr. Fon coined the term. Okay.
Yes.
I just want to make sure I understand. Andrew, you do not have Parkinson's.
Not that I know of.
You have dystonia.
Yes. Yes.
Right.
But
Okay.
interestingly enough, my dad did have Parkinson's.
Are they related in terms of the dystonia? In other words, Andrew's father having Parkinson's, would that have affected Andrew with the dystonia?
Okay. Yeah. So I think the question is Parkinson dystonia related? So in general, no. Most people we see with dystonia, for example, affecting the eye, the neck, or the writer's cramp, or with the hand like Andrew, do not have Parkinson. Now, having said that, it's actually quite common for people to have dystonia. So sometimes we see people with Parkinson have the foot cramping, like the curling of the toes, turning in of the ankle is a quite common phenomenon. So this is a dystonia. Okay, that's why I said dystonia is a syndrome. So Parkinson can have dystonia as part of the manifestation of Parkinson's disease. Yeah, and there are also some very uncommon conditions that have both Parkinson, dystonia, but I think we don't need to discuss those.
Most people with dystonia beginning in adult life, like you've heard, isolated writing problems, don't evolve to develop Parkinson's. And as Dr. Chen has indicated, we see patients with the eyes involved, the face, the neck. These are relatively common, what we call adult onset focal idiopathic, meaning we don't know the cause, idiopathic dystonia. However, Parkinson's disease and Parkinson's syndromes, people with other causes of Parkinsonism, not uncommonly have dystonia. It's usually something that occurs later in the course of the illness in those people. Rarely do we see it very early on, so it would be really quite unique or unusual for you, for example, you asked that question, for you to evolve to having Parkinson's. It's probably unrelated. But Parkinson's patients can benefit a great deal from botulinum toxin injections as well.
Thank you for your talk, Dr. Chen. My question is, can you go back to the first part of your talk and remind us again, or tell me, because I don't understand, what is the practical implication for someone with Parkinson's to have restored or plasticity? Like what benefit will the person with Parkinson's get from that?
Okay, that's a very excellent question. So now this is something that we and others are still doing further research on, because what we showed, we have find something abnormality in people, say a brain connection or plasticity. So we're looking at ways to restore it, and often it is a treatment that also works. For example, deep brain stimulation. Right? So deep brain clearly works, and it also makes plasticity better. So what we're trying to do, I think the next step is if let's say we can make increase brain plasticity in people with Parkinson's, for example, by combining this magnetic stimulation with deep brain stimulation. So the next step is to see can this be a new treatment or a better treatment? But that would be the next step, I think. Yeah.
Yes, over here.
I have a question for Andrew. I have hand dystonia in both hands as well, and you had mentioned the invasive mechanism that went on your head. You didn't have deep brain stimulation though, did you? Like where you had an operation, you just tried the invasive pattern? Like can you do that without actually having deep brain stimulation, and is there an effect with it?
Well, that stimulation I mentioned, that was just part of the study. It wasn't a treatment. Like it was part of.
So you can't have that unless you have the deep brain stimulation. Like that you can't have one without the other.
No. No. You can have one without the other. So what Andrew participated is a research study. So he had magnetic brain stimulation, just putting the coil on the surface of the head. So that stimulation is not a treatment. We are just looking at what happened with the botulinum toxin treatment. So we have different ways. So sometimes we can use this as a treatment, but often sometimes we use it as a measure. So Andrew participated in the study, we're using this to measure the brain, or to see how the brain is, rather than as a treatment. So, but to answer the question, yes, you can have deep brain stimulation, definitely. You don't need to have the magnetic brain stimulation. On the other hand, there are treatment with magnetics, for example, people being treated for depression. We have done studies in people with Parkinson's disease and dystonia as well. You can also use this magnetic stimulation as a treatment. You don't need to have deep brain stimulation.
Okay, but like it won't actually, like I know there's no cure for dystonia, but like it actually won't, like will it make you symptom free?
Yeah, right. So when we do the treatments, the one that Andrew participated is not designed to help. We're just looking at what's wrong with the brain in people with dystonia. But there are certain studies that were designed as a treatment. Then the hope is to help people with either Parkinson's disease or dystonia. So certain studies, so for example, it would be sometimes we just finished a study on Parkinson's disease. So it was similar to, some you may have participated in like trial of drugs. So sometimes there's a real drug, sometimes a placebo drug. So sometimes we do studies, we have a placebo stimulation and a real stimulation because we want to know whether it works or not. So when it's a treatment study, then yes, and the goal is to improve symptoms, improve things in people with Parkinson or dystonia. So I think it's depending on the goal of the study. Sometimes we want to, in this part, so often to do a study, we first understand first. So often the first step is just to understand what's the problem. Once you have better understanding, then we can design the next study to be as a treatment. So some study is designed to understand the problem. So some study we design as a treatment.
Okay, thank you.
Typically, the treatment component, as Dr. Chen mentioned at the early part of his talk, involves what's called repetitive transcranial magnetic stimulation, or RTMS. What you saw in the demonstration were individual TMS stimulations. And so if you're doing RTMS, it wouldn't be practical to be doing it at the level that you saw with the stimulation. What you saw was what we call suprathreshold stimulation to induce a muscle contraction. Most of the treatment where you use repetitive stimulation, you're doing it in different areas of the brain. So if you're depressed and you're being treated by the psychiatrist, you're not stimulating the motor cortex. You're stimulating parts of the brain forward from that we feel are more a part of mood and behavior. And you're stimulating them at below threshold so that the patient isn't experiencing what you heard Andrew describe. That's something that might happen in an experiment, but it's something that's not practical in terms of long-term therapeutics. Yeah.
Andrew, you mentioned that you had the problem with your right hand, and then you came to this realization you could use your left hand.
Yes.
Perfectly okay. But it only lasted a certain amount of time. So I'm just wondering, what is your perception of what was going on physically or mentally there? Yeah, I know you're not a doctor, but what is your own...
Well, I actually am a doctor. I have a PhD. But these guys don't recognize that, right? That's why it doesn't appear here.
In that case, I ask my question again. As a doctor, what was going on there, physically or mentally?
Well, since I've studied the work of a guy by the name of Sigmund Freud, I would have some depth psychology interpretations of that. I really don't know. I'd have to, continue my in-depth psychoanalysis in the analytic session to come up with a why. I don't have an answer.
Right.
It's very weird because now I can sort of write with my left hand, but not as well as I did during that five-year period. I mean, I could write an exam in no time flat, with my left hand. Right now, I struggle writing, but I can still do it with my left hand.
Yeah.
So
I would say I think what Andrew described is not uncommon. So I mean, people who write cram, they will try to use don't use the left hand to write, and many time people will also develop dystonia on the left hand after a while. So we think what happened is that there is some abnormality in the brain. Often we think there's actually abnormal brain plasticity, but it is actually not just limited to the brain that controls the right hand or the writing. It's just that we only use the right hand typically because it typically affects a highly skilled task. So like writing, sometimes we have also people who play musical instrument can be affected. Usually it's a skill task. So usually people only use the right hand for writing as a skill task. And when you do the left hand, because the brain already have this underlying abnormality, like a normal plasticity, for example, then it will develop this problem after a while. So we do see that happening.
Typically, in someone with writer's cramp who is very disabled and can't write, we tell them, you can try learning with the other side. It takes about 6 months of regular practice to become proficient in writing with a non-dominant hand, but you are at risk of developing the same problem with the other side. We just don't know who's going to get that. And in fact, that would be a research study. Right? You would be if you could collect enough patients that did that and then demonstrate some of the electrophysiological abnormalities that Dr. Chen demonstrated today that were particularly prominent in the people who got it when they wrote with the opposite side and not see them in those that didn't get it, that would really explain a lot about what's going on in the brain. Yes, I saw. Oh.
I have a dozen questions. Dr. Norman Deutsch wrote a book about how the brain heals itself, and in it he talks about a man with Parkinson's, I think who lived in South Africa, who retrains himself to walk a normal walk rather than the small step Parkinson walk. Does that have anything to do with brain neuroplasticity?
Yes, I think so. Yeah. So I think many who Parks will For example, walking often is easier if the lines, you can step over it. People dancing, people say is easier than walking, something like what people will tell us. So what we think that there is a brain system that still works and often involving a pacing, like a dancing has a rhythm to it, for example. So I think what probably one example you give is that person is training himself to use an alternative system, the brain. That is still working. So like the dancing, for example, you can walk, for example, to a pace. So I think, yes, I think this is an example of brain plasticity. So normally you don't use that to walk, but he is training himself to use that system that is still rather intact to be able to walk.
I can't avoid commenting, though, those in the room that have heard me speak about this guy. In fact, that is brain plasticity and training and learning. It is not healing the disease.
Yep.
And this man claims, through the writings that he does, that he is healing the disease. The disease process is reversing. There is absolutely no evidence for that. And I think his claims are hurtful. His claims are not good for our field, to be honest with you. Okay. Yeah. I'll get to you, too. Don't forget.
Okay. I have a kind of a strange question. When I first was diagnosed, I had, they said it was essential tremor, and then I couldn't write. And to this day, I can't really write, but I've been diagnosed with Parkinson's. And I'm just wondering, I've had a feeling in my heart all along that I didn't have Parkinson's, and I thought maybe it was, now I'm thinking maybe it was dystonia I've had. And is there a real difference?
Yes, so I think, as you mentioned, for example, essential tremor, Parkinson, dystonia, yes, so they are different, in terms of different conditions. Now, sometimes we do see people have both. For example, we see people who have essential tremor, then later on they might develop Parkinson's disease. So obviously, having one, you're not immune to having another conditions. But yes, in general, I think they are different. Now, occasionally, there are people with tremor that when we first see them, we may have a question mark, whether this is essential tremor or Parkinson. Usually they are separate, but occasionally there can be a difficulty in distinguishing it. But usually over time, we can tell the difference.
Yeah, writing is a problem with a lot of what we call motor disorders or movement disorders, and writing can be a big problem in Parkinson's disease, not uncommonly an early symptom. But also some patients, a little bit contrary to what I said earlier, some patients can present with a writer's dystonia and as their first manifestation of Parkinson's. But that's uncommon, but it's hard to know what you have. Yeah, question over there.
Thank you. I think my question was just preempted. I was going to ask about handwriting. Deterioration of handwriting is often a common symptom early in the Parkinson's disease, one of the first things that points to that possibility. And I was wondering if it was totally coincidental that that is the case. My brilliant note says, PD, yes, impairment of handwriting is often an early symptom. And is there any connection or relationship to dystonia? Is it just totally coincidental that that is the case? And I understand it is totally coincidental.
Yeah, I think that, yes, I think often impaired handwriting is a symptom of Parkinson and dystonia, but usually the type of impairment is different. So in handwriting, often the writing becomes smaller, whereas in dystonia it's different. Usually, there's abnormal movement of the finger. So that's, yes, they're both impairment, but usually the nature of it is different.
That's why you need to see a neurologist that knows what they're doing, obviously. And when we see patients presenting with writing disturbances, we evaluate them very carefully for a variety of problems. And as you heard earlier, it's a task-specific abnormality in the early writer's cramp. So when we get the patient to do all sorts of complex tasks when they're not writing, you see nothing. Then they pick up the pen, and that's when the motor problem occurs. Whereas in somebody with writing difficulties with Parkinson's, they often have some slowness and stiffness, and so our careful evaluation will show that. Yeah.
I just wanted to check, I have the dystonia because I had a brain hemorrhage. Oh, okay. I had a brain hemorrhage, so I'm wondering, because I'm not at all being a candidate for the invasive stuff, but can the non-invasive stuff help with hemidystonia as well? Yeah?
Yeah, so
Thanks.
I think the answer is we need to do some more work on this. I think, so in a sense that there are a lot of numbers that are done in people with stroke. Now often people with stroke have spasticity, which is not exactly dystonia, but we can say with stroke is somewhat related. So there are some studies in stroke, post-stroke. So some are promising, but currently I think is not ready as if you like, a standard treatment at this point. But I think that certainly there is, again, for brain plasticity, the role to maybe promote the beneficial type brain plasticity in this situation. Yeah.
Any other questions? Yeah.
What are the success rates with regard to cervical dystonia and this combination of the deep brain stimulation and the other non-invasive?
Right. Okay. So, right. So now the cervical dystonia, I was first of all, these are not the first treatment. Usually we use botulinum toxin as the first treatment because they're often much less invasive, sometimes use medications, but we use deep brain stimulation in certain people who doesn't respond to the other usual treatment, who obviously we evaluate that. So deep brain stimulation is a treatment for people who doesn't respond to other less invasive or standard treatment. Now the magnetic stimulation that we see is currently not a standard treatment. So it's a research. So I think that this is something that we will other people work on in the future. So maybe even combined with deep brain stimulation, but currently is not a standard treatment. There's something we need to do more research on and to see how that works. Yeah.
So one of the things you get in these sessions is cutting edge stuff that really hasn't hit the common market yet. And we obviously recognize the need to do things better. And each of the things that we're providing for patients with the various different conditions we're talking about can help some, but they still leave a lot of unanswered questions with a lot of patients with symptoms that we're not adequately handling. And we recognize that, and that's why these kinds of things need to be advanced. Any more burning questions? I think we've got room maybe for one more. Last one.
My question is just regarding the papers that were discussed earlier that paired deep brain stimulation and medication. From my understanding, that they increased brain plasticity, the response. Does that mean that the brain was more capable of making new connections? Is that what it was saying?
Right. Yeah. So I think the question is that means activating a new connection, right? Yeah. So what I don't probably not acting new connection, but what we think believe doing, we are strengthening certain existing connections. So we think that by different timings, we are looking at different connections. So we really think that we can, by doing this individual, can strengthen a specific connections. But I think what the next step is so we first show that we can do it, but to make it last, we're going to have to do it repeatedly, and we have to. The next step, the research would be to see if strengthening this particular connection will have an effect on the clinical outcome. That will be the next. I haven't done that one yet.
And I was just wondering, they were pairing the deep brain stimulation with certain medications. Did they say what medications they were using in the study?
Oh, okay. Oh, so in the study in people with Parkinson's disease, so they are basically is the usual medication that we don't change their medication. People. So I mean, typically is levodopa, and then together with some other type of medication. But in the study, we just have people on whatever medication they're normally on. Yeah.
Okay, thank you.
Okay, so I think we're going to call it quits. This has been, I think, a great session. You've seen some cutting-edge technology. You've heard from a world leader in his field. I think that We are here, as I told you, to try to provide you some insights into what's going on in this field, give you an idea of what we're doing in our research programs. You saw from the slide that Dr. Chen showed earlier that we have 9 full-time faculty members. Each of us are rotating through the speaker series. If you have any topics related to your disorder or movement disorders in general, or if you're being cared for by one of the faculty members that you'd like to hear from that hasn't spoken yet, please let us know. We discuss these sessions in our faculty meetings along with the foundation representatives, and we're doing this now biannually, I guess, so we'll be coming along probably in another 6 months for another session. I'll just remind you that if you're interested in hearing more about the research that you heard about today, or you'd like to volunteer, despite what you heard earlier, we have some people with trainee name tags that I'd like you to approach. If we don't have your email address for these sessions, or if you have additional questions, or if you have additional suggestions, please speak to Steph Finley at the back there. Wave your arm so that you know Stephanie's standing there. So she'll make sure you're on the mailing list and make sure that we get the input that you have. If you have any positive or negative input on these sessions, we want to make them valuable to you. We want to optimize what you get out of them. And I hope you've got quite a bit out of it today. I'd like to thank Stephanie, the foundation, for supporting us today, and Liza, who couldn't be here, for her push and her idea to make these happen. The Milnes, as I say posthumously, for their ongoing support for the session. To Dr. Paskakis, for his participation. Got him. And Dr. Chen and his team for the presentation. Thanks very much.